presented by Dr. Taifun Turan. Thank you very much. Good morning, everybody. I hope I will be able to provide some useful information for you. First of all, this is a reminder for you, the first slide. We will be talking about testosterone and dehydroandrosterone. This is the synthesis with the substrate of cholesterol. Everybody knows this, of course, but I just wanted to remind you. I need to separate my lecture into three parts. First, we will look at it from the female perspective, and secondly, we will talk about hormonal relationships in males, and finally, I will mention DHEA, because this is still a controversial issue. In general terms, in females, androgens are produced by ovaries and adrenals. And from the peripheral tissues, a part of it is also produced. And almost half of androgens are testosterone. During the pre- and post-menopausal period, there are, of course, some differences in terms of production. The main source of testosterone are adrenals. And after the menopause, the main reduction results from the adrenal glands. The testosterone in circulation is not all free. 1/3 of it is bound to globulins, about sex hormones, and they are bound to the sex hormone binding globulin. This is the passive part, it's not effective. This is 2/3 are bound to SHBG, 1/3 is bound to albumin, and around 1 to 2% is free. The active part is composed of the albumin bound and the free portion. Frigidity is defined with DSM-4 diagnostic criteria. The inability to have sexual fantasies and decreased libido, which causes a distress in the sexual partner. This is the main outline of it. Among the females, reduced sexual desire. This is mostly a topic that involves males. However, of course, there are cultural differences, but it's usually neglected. However, if you look at the figures, decreased libido among all the sexual dysfunctions, it has a share of 20%, 85%. And 20% of all the females throughout the world have decreased sexual desire. This is a multifactorial issue. It doesn't have a single cause. The hormonal etiology is only one among those, and the most important one are psychosocial causes. We also have psychiatric disorders such as major depression. We have certain chronic disorders, and some drugs that we frequently use lead to decreased sexual desire, especially menopause, advanced age, or diminished androgens are only one of the many causes of this condition. An androgen deficiency manifests itself with symptoms including decreased sexual desires, fatigue, poor mood, and lack of motivation. What is the relationship between testosterone and sexual desire? If you look at it from the general perspective, we have some population-based studies that have been conducted so far. These studies, if we take a close look, we may draw certain conclusions from the results of these studies. For example, just to cite you a few of those, the mid-cycle sexual activity and serum testosterone are related, and some other investigators failed to establish such a relationship. However, if we wrap it up, we still don't have a clear picture on the association of testosterone and the decreased sexual desire. This cannot be concluded from the population-based studies. The sulfate decreased levels of DHEA may be associated with decreased sexual desire. A great portion of these population-based studies are conducted in the postmenopausal period, and we also know that the prevalence is greater in this patient population. And finally, in decreased sexual desires, the androgen levels may be normal. However, decreased levels may also be associated with decreased sexual desire. And then we have some studies on replacement of testosterone among females. Although the number is not very high, if we just take a close look to the replacement therapy studies, ever since the 80s, we have more studies available to us on replacement therapies. There are some common characteristics of these studies. The initial studies were conducted using the oral and subcutaneous administrations, and the more recent ones tend to use the gel formulation. And the most recent studies the previous studies had only limited sample size. The recent ones are larger, and the recent studies are placebo-controlled and double-blinded. But there is a common definition in all the studies. The total and free testosterone level cannot be identified using a safe lab technique. And for this reason, it is hard to define a lower detection limit for female patients in terms of testosterone level. Which conclusions can be drawn from these studies? These testosterone replacement therapies improve the sexual desires in overall. There is an increase in satisfactory sexual activity, and as a result, it also reduces the stress between the sexual partners. These skin patches, especially the gels that have been used recently, are safer to use, and this improvement is observed without the testosterone level reaching the therapeutic range. In general, although it is used in different doses, 300 micrograms are considered to be more safe in terms of dose range. If you look at most of the studies, mostly testosterone is not used per se. It is usually combined with estrogen preparations. As it is true for the population-based studies, they mostly involve the postmenopausal period, or surgery-induced menopause patients are included in these studies. But still, although there are some preparations that do not have FDA approval, but still they are prescribed very frequently to the women with impairment of sexual desire. And the follow-up period is very short. The longest ones extend only over 2 or 3 years. So far, we haven't observed serious risks, but for the future, we don't know what kind of side effects or complications will develop. This information is something we are still lacking. With the decreased sexual desire and testosterone level appear to have some sort of a link. Testosterone increases the sexual desire, and it appears to be independent from the plasma levels, and increased dose does not mean more sexual desire. This is a conclusion we may draw from some publications in the literature, and especially surgical menopause is more frequent among these patients. Impaired sexual desire is more frequent among surgical menopause patients. Epidemiological studies show us that with the testosterone administration we have an increased risk for breast cancer. However, in these studies, which extend only over 3 years, this risk was not identified. However, epidemiological studies show an increased risk for the development of breast cancer. There are no testosterone drugs that are specific for female patients. Probably we need some studies on this issue. And instead of testosterone replacement therapy, maybe over the time DHEAS may be used for this indication. What are the risks in general terms? First, with testosterone, the cardiovascular system may be at risk. The lipid profile is decreased with testosterone. It may lead to hirsutism and acne. Weight gain is controversial, and as I was trying to say before, and the issue about breast cancer, it is suggested that the risk increases. However, in epidemiological studies, there's additional mention of risk-benefit ratio, and it should be left to the individual, whether the individual is willing to take more risk in terms of breast cancer to improve sexual desire. Who should receive this drug? If you look at the female population, all the other causes need to be excluded. If there are psychosocial causes, they need to be treated first. If there is a psychiatric disorder, it needs to be addressed first. These drugs, testosterone replacement, should be considered as a last resort. Especially patients who had a surgery may be eligible candidates for this therapy. There are some contraindications, including androgenic alopecia, seborrhea, acne, hirsutism, pregnancy, lactation, polycystic ovarian syndrome, or its history, dyslipidemia, or liver disorders are among the contraindications that are listed for this therapy. There are various routes of administration for the therapy. As I said before, in the recent years, gel formulations are usually preferred in the studies because they don't result in supraphysiological levels which may avoid the side effects that are associated with therapy, and therefore gel formulations may be preferred in the patient population. However, other methods such as subcutaneous administration or sublingual formulations or intramuscular administrations are other available methods. However, they lead to supraphysiological levels among women. What is the relationship in male patients between testosterone and impaired sexual desire? Decreased sexual desire may also be seen among men, but however, it's usually neglected. I think it's not part of the agenda of anyone. The prevalence may differ from one publication to other, and it's usually cited between 0 to 15%. In fact, impaired sexual desire among men is overshadowed by sexual dysfunction. According to the results of my personal screening, decreased sexual desire per se is usually not cited in the literature. It's usually always taken together with sexual dysfunction in all of the studies that are cited in the literature. The most important cause is aging among men. In patients with erectile dysfunction, decreased sexual desire is seen in 40% in these patients. Maybe the main focus should be this issue. This may be a result, especially for some cases, this may hold true. Well, in men, testosterone is produced in the testes, in the Leydig cells. In the early morning, the peak levels are achieved. With increasing age, the hormone levels decrease. from 30s onwards, it is decreased by 1% annually. In men, the androgen level is much higher compared to women, and it's easier to measure compared to the female population, and it's easier to report them. The normal interval is usually suggested between 300 to 1000 nanograms per deciliters. However, there are some differences between the different laboratories. Overall, in some of the studies, between the lower and upper limits, there is no significant difference between the two levels. Only in people with a very low level, testosterone replacement may benefit the patient. Adam yoruldu galiba ya, çok garip. Okay, we have some general information on male patients. Maybe we should also mention hypogonadism from androgen and testosterone deficiency. It will all be discussed in the next lecture from different dimensions. Here again, we have an increased level of sex hormone binding globulin level. We have a testosterone deficiency. We have a decreased sexual desire, erectile dysfunction, we fatigue, mood disorders, as well as others. And the prevalence is around 10%, between 50 to 59%. Between 60 and 69, it's around 20%. After 80 years of age, it's seen in more than 80% of our patients. Decreased sexual desire is usually not the topic of any study among men. However, in combination of erectile dysfunction, we may come across some studies in the literature. If you look at the results of these studies, as I said before, it's usually overshadowed by erectile dysfunction. We need to underline this fact. However, if you look at the studies, a relationship is established between testosterone deficiency and decreased sexual desire. These studies focus on erectile dysfunction. However, we see that testosterone levels are more linked with the sexual desire rather than erectile dysfunction. In men, there are some risks that are associated with this therapy, such as sleep apnea, gynecomastia, again, and prostate cancer. Risk is also present among men, and we also have edema as a side effect. Again, long-term studies are missing also for men. If you give this therapy to suitable candidates, there will be some benefits, including improvement of the quality of life, increase of energy levels, etc. There are many different routes of administration, as we have said before. The trend is towards gel formulations also for men. They are easier to use, and again, it doesn't exceed the physiological levels in men, and therefore gel formulations or slow release preparations are used, depot formulations are used. They are not as good as gels, but still, such as undecanoate, physiological levels are not exceeded. As far as I could find out from the situation in Turkey, we have different formulations available in the market. Testosterone administration in men, if this therapy is considered, certain factors need to be taken into consideration, such as we need to monitor the response to therapy. The blood levels need to be tracked, hematocrit levels need to be checked, and the patient needs to be followed with regard to sleep apnea. Bone density needs to be monitored, and the rectal examination plus PSA levels need to be monitored as well. There are many causes for a decreased sexual desire. In talking about the men, first of all, you need to exclude all the other potential causes of this condition. even only if you identify testosterone deficiency from the laboratory results, only then you should consort to this therapy. You should always consider the risk-benefit ratio. As I said before, gel formulations or slow-release formulations of undecanoate may be used because they appear to be safer. And in men, the long-term effects of this therapy are not known. You should always think about this first. You need to discuss all these issues with the patient, and a common decision needs to be taken. And finally, very briefly, on the role of DHEA in decreased sexual desire in men and women. Again, here we have just to remind you, the synthesis of DHEA with the sulfate derivative. This is the pathway that originates from cholesterol. It's a it's a hormone with a weak androgenic effect. In Europe, it's considered to be hormone. However, in USA, it is sold over the counter and is considered as a food supplement. The effect is exerted after transformation to dehydrophenol. If you check the literature, sexual desire and sexual, could you please wrap it up a bit more quickly? You have exceeded your time frame. And the relationship, and studies on this relationship are very scarce. Rather than men, the sulfate derivative of DHEA may be associated with decreased sexual desire in women, because it's more important among women, because in men we have much higher testosterone levels, which overshadows the effect of DHEA. Among women we have a limited number of studies in the literature. And another important point on DHEA, especially at the end of the 90s and beginning of 2000s, there are some studies on DHEA. However, the results are contradictory. Recently, people appear to have lost their interest on this substance. Maybe among women, the weak androgenic effects may be beneficial for the decreased sexual desire, and we may try avoid the side effects using this preparation. The side effect profile are quite similar to testosterone, but they are weaker. Another important point that I need to emphasize is DHEA is usually sold over the counter, and it's not a prescription result. Thank you very much for your patience.